left then with a very exciting opportunity for thinking more, I think, creatively around how to target CD38 in relapse. Obviously, daratumumab re-challenges, daratumumab frequency, and all of these important moves can be very helpful to patients. So someone who's on daratumumab maintenance, you can simply increase the frequency of daratumumab therapy. You can add drugs to it rationally and see restoration of response. The area of daratumumab resistance, though, is particularly complicated. For example, at the ASH meeting this year, we presented data from the isatuximab studies looking at whether or not CD38 levels correlate with outcome. Interestingly, the data from both phase 3 and phase 2 studies did not support that. Therefore, as you think about CD38 expression or circulating levels of CD38, obviously those are going to be low after daratumumab exposure. And that raises the very important question of what kind of antibody do you then deploy? And I think as we think about sequencing of antibodies, these are all kinds of important considerations to think about, because obviously we reach for BCMA targeting strategies after targeting CD38 has failed a patient. And that's an important new avenue, and there were a tremendous amount of data at this year's ASH meeting to support that, not least of which with antibody-drug conjugates and also with, of course, the cellular platforms and so-called BiTEs, bispecific T-cell engagers. However, I think in community practice, it's important to recognize that these approaches remain experimental and areas of research, and access to them can be not that easy. So with all of that in mind, when we have the advent of a CD38 targeting antibody that's qualitatively different in its properties to daratumumab, I think that's a very important contribution and provides us with the opportunity to think very creatively about combination strategies. So as you think about, for example, diffuse large B-cell lymphoma, and you use Rituxan, CHOP, Rituxan ICE, Rituxan EPOCH in sequence, it may well be that in myeloma, which is, in my opinion, humbly, a much more complicated disease, you may be thinking of a different CD38 approach. In other words, you may be deploying DARA up front, using DARA in maintenance, but then you may be rationally thinking about, I target CD38, but I might want to think about a different CD38 antibody in order to optimize outcome.